All right, thank you very much. We really appreciate being here. And it's great to talk to everybody. And I love this concept of Th1nk26. When I first saw it and heard about it, I thought it was so creative. So kudos to y'all for coming up with this so quickly. My name's Amy Ennis, and I work for UCB, where we are inspired by patients and driven by science. Every day, our priorities are to improve the lives of patients living with epilepsy. UCB continues to partner with organizations like the Epilepsy Foundation of Colorado, and we're happy to work side by side with y'all and them so that together we can overcome epilepsy. Tonight, briefly, I'm excited to share with you 4 resources that we have at UCB. And let me see, is there a way for me to minimize? Can y'all see the resource, or can I minimize this little screen? There we go. Is that easier to see my screen?
That looks good.
Okay, perfect. Okay, so the first resource that I want to tell you about is our Exploring Epilepsy series. It consists of 3 modules. They're available in either hard copy or online. The Epilepsy Foundation keeps a stock of the hard copy books, so if you're interested in those, don't hesitate to reach out to the foundation. But you can also access them online, and the website is right here. It's just www.exploringepilepsytoday.com. So there's each module covers a different topic, but there are things that are similar in all modules. Each of them has a healthcare lingo, which is kind of like a glossary or a dictionary of some of the different terms in it. There's a frequently asked section in each one, and then there's also a perforated resource that can be torn out and used, and it always will relate to whatever the topic of the module is. So this first module, you'll see them listed here. This is Module 1, Module 2, and Module 3. So in Module 1, it's really an Epilepsy 101, and it covers topics like what is epilepsy, how is it diagnosed, what's a seizure, what causes a seizure, what are the different types of seizures, who are the members of my healthcare team, so things like that, just some basic information around epilepsy. And the resource in this module is a discussion guide that you can use when talking with your healthcare provider. The second module you can see right here is epilepsy medication therapy. And it kind of gives a broad overview of anticonvulsants, their benefits, their challenges, how to choose the right medicine. It doesn't necessarily go into each drug specifically. It just kind of gives an overall generalized view. And its resource is a seizure diary that you can tear out and utilize, make copies of, things like that. The third module right here, the third module is titled Epilepsy Support and Non-Medication Management. And it covers safety and quality of life type topics like SUDEP or wellness. And its resource is an action plan. And it's a great module. It really relates to tonight's topic of safety. So it's one that is very relevant to tonight's conversation. The hard copies are all available in English and in Spanish, and the online version is only in English, but it can be viewed online, or you can download it and print it out if you'd like to do something like that. The second resource that I want to share with you is our Epilepsy Advocate program. An Epilepsy Advocate is a community of people living with epilepsy and their families and their caregivers. As you all know, when it comes to epilepsy, knowledge is power. So whether you've had epilepsy for years or you've just recently been diagnosed, the more you know, the more you can, try to control your epilepsy and live the life that on your terms, the life that you choose. There are several components to our Epilepsy Advocate program. You can see some of them listed across the top of the page here. There's obviously this website, there's a blog, there's a Facebook community, there is a magazine. So you have all types of resources that you can find when you go to this website, which is www.epilepsyadvocate.com. So I encourage you to take a look and see what it has to offer. The third resource that I want to show you is actually our newest resource, and it is a YouTube playlist. So it's titled Epilepsy Behind the Scenes, and you can either go directly to it by typing into your browser, www.youtube.com/user/epilepsy advocate, or it's much more simple. Just go to youtube.com and search for Epilepsy Behind the Scenes. And what you're going to see is a playlist. There's 6 different little short videos. All of them are under 2 minutes, and they have patients and their caregivers that are talking about different scenarios with epilepsy. And you can see across the bottom of this screen, some of the topics are lessons from epilepsy or receiving advice after diagnosis, the benefit of knowing others with epilepsy, finding your support system, breaking the epilepsy stigma, and being your own advocate. And the 4th resource that I want to share with you is actually our resource that's been around for the longest amount of time. It's called Ucb Cares. And really, Ucb Cares, it isn't a call center like you can see here on the screen. It's really an answer center. And we really pride ourselves on being able to answer questions in a caring manner, and really trying to make sure that we find the best answer for you. So if we don't know the answer, then we'll figure it out, find it out to the best of our abilities, and be able to share that with you. You can see here on the slide there are about 5 different areas where we can answer questions: product support, clinical trial support, medical information, patient solutions, and patient assistance programs. And you'll notice that everything that you see here is kind of based on or related to a product. So our Ucb Cares program is all focused around products that we have at UCB. You can access it 3 different ways. You can use the phone, or you can use email, or you can use the web address of askucbcares.com. And if you're not sure what the different products are for UCB, what's in our product portfolio, then you can find a list by disease state here at this www.ucb.com/r-products. And that'll give you a list of what the different products are that UCB Cares would support. So in closing, I just really want to thank you for your participation and your engagement. When the Epilepsy Foundation of Colorado asked us to support this event, we were so honored. And I want you to know that, our support doesn't end with this event. At UCB, like I said, we strive every day to help people living with epilepsy through science, education, and advocacy. And we recognize you as a courageous fighter and those that support all of us in sharing your cause. So just know that we at UCB are here to support your journey. Remember that you're not alone. Keep your heads high and don't back down. And along with all your family and friends, we're here for you to help you through any of the challenges that you might have. So that's it for me. So thank you again. I really do appreciate your time.
Yeah, so my name's Chelsea. I work at Children's Hospital. I've been in epilepsy for 10 years and been to camp lots of times, and safety is my jam. So next, disclaimer, make sure you talk to your doctor about the things that I tell you about. Epilepsy is so different from kiddo to kiddo and adult to adult that, anything I say really should be taken into context to each patient. So I feel pretty strongly about that. That's not just a legal disclaimer, I don't think. I think we're lost. There we go. Okay. Basic facts about epilepsy, of course. I'll skim through this because I feel like lots of people probably know this, but what is a seizure? It's a brief, strong surge of electrical activity that can affect parts or all of the brain. Epilepsy is very common. 10% of the population will have a seizure, but only 1% are diagnosed with epilepsy. What is epilepsy? It's 2 or more unprovoked seizures. Now that definition has changed, it's, I think in 2016 or 2017 to be a single seizure, and something about the patient's history, EEG, MRI, past medical history that would leave the clinician to give the child a greater than 60% chance of seizing again. So in our world, that's a single seizure and an abnormal EEG or an MRI that it would explain their seizures. There are lots of people out there with epilepsy. Teddy Roosevelt, Lil Wayne, lots of people famously have had epilepsy. So it is not a rare thing. Next. Common triggers, I think every kid is pretty different for every, sorry, I say kid because, you know, children. But every person's triggers are different. I can go over the common ones. I would say fatigue and sleep deprivation. The thing that I hear the most in families is, you know, I picked my kiddo up from soccer camp in the mountains, and they were up all weekend, you know, was super tired, and then fell asleep in the car because they were so exhausted, hadn't slept all weekend, had a seizure on the car on the way home. That's really common. So poor sleep pattern, poor sleep, missed medications, which is obvious. Illness and fever, stress. Now that can be good and bad stress. I feel like stress, like emotional stress is less. I feel like physical stress is a little bit more. Flashing lights is not common. Flashing lights is not a common trigger in seizures. And I put that on there. I put that asterisk there because I want to make sure that people know that if you've had a routine EEG, we have probably flashed those lights at you. Those lights can tell us if you're sensitive to that or not. And so we don't need, most people with epilepsy don't need to like avoid all things with lights. Heat, dehydration, and puberty. Puberty is kind of a make or break for seizures sometimes. Sometimes, you know, actually the data is a third get better, a third get worse, and a third there's no change. And next. So safety, swimming can be tough. It kind of depends on the frequency of your seizures. I say I would use more than the lifeguard. I would use an adult in the water with the child during, and make sure that that child knows that that kiddo has seizures. So not on a chair or person, sorry, or adult, not on a chair at the poolside, but rather like legs in the water, at least, preferably within arm's length, especially if they're common. Now, if you go years seizure free, could you start to feel relaxed on that? I think so. But that's kind of a question to ask depending on your seizure frequency and seizure type with your provider. Next. Bathing, kind of same thing. So water is a risk. We recommend showers, not baths. If baths are required due to development or age, then we recommend that someone's in there for the duration of the bath. And I would not have a lock on the bathroom door. I know teenagers and adults that want to live independently, that can be a sticking point. So you can make put a sign on the outside of the door that says showering or privacy please or something like that. But they, we do need adults to get in at all times. Next. Fire safety. So this kind of just makes sense because I feel like, unattended flames are just a risk in general, but it goes without saying that use the back burner, don't leave flames unattended, put guards on, make sure you put guards on fireplaces and things like that. Set the max water temperature to 110 because if someone is, I recommend this because if someone, when it's cold outside, it's not right now, but if it's cold outside, when I go in to wash my hands, the first thing I do is I turn on the heat, right? The hot water, and then it warms up and I'm washing my hands. And then when it starts to get too hot, I turn on the cold. If someone has frequent absent seizures or seizures where they are briefly unaware, if that water continues to get super, super, super hot and they're unaware, when it's too hot, they can burn their hands. So I'd recommend somewhere between vacation, around warm-ish is good. You don't have to go all the way vacation. I think that's real cold, but consider reducing that temperature. Next. Oh, there we go. Okay, climbing. So I would not recommend, if someone has frequent seizures, I would not recommend climbing on a ladder or the roof. In general, we recommend climbing no higher than one's height. That being said, there are things, if the object they are climbing is not reasonable to place restraints on, the supervision is recommended. That being said, so if it is a climbing wall, if it is a zip line where they're harnessed in, they're helmeted, where there are kind of precautions around that. If it's monkey bars, if it's something where falling from that type of thing happens, like the monkey bars, we still recommend people continue to do that. Just be diligent that kids fall from the monkey bars all the time and they don't have seizures. And then you just might be at risk for falling more. It kind of really depends. There are some, playgrounds with really tall slides, or if someone as they're going down had a seizure from the top, that could be dangerous. It kind of just really depends on frequency of seizures and if they're drop seizures or partial seizures. But I would also say that if there are things that they're climbing or doing that involve wear a helmet and a harness, or if they're roped in, for the most part, that's pretty safe. We do that at camp. So climbing walls, rope climbing, zip line, that's all fine. Soften sharp edges in the house. If someone has frequent seizures or drop seizures, that's definitely something to take into consideration. Just like the little foamy things you get from like baby stores is pretty good. Next. So sports, ask your neurologist about specific sports. The reason why we get kind of, the thing to think about with sports is, go back. If you have frequent seizures, would that put you at risk for being like tackled or run into by a player? If you get hit in the head by something, that could provoke a seizure a little bit more likely than someone without seizures. In general, though, I got to be honest, we do recommend, it's kind of one of those risks benefits things where we recommend kids doing things that allow them to be children or do things that are fun. So water sports may be kind of tough. Tackle football is a little bit of a tough putt for anyone who works in neurology, but probably every other sport we do recommend people do in order to feel human and engage socially. Those are things that are really important and should be valued. So if it kind of, again, this is one of those things, again, that depends on the frequency of seizures and type of seizures you have. I have no issue with any of my patients sending me a question sports specific. Is it okay if my kiddo goes hiking? Is it okay if my kiddo goes camping? Those types of things. Is it okay to do soccer or cheerleading? I'm happy to answer those questions in the context of that person's seizures. So you just have to, never hesitate to ask. In general, I think we recommend that like social engagement is awesome because epilepsy can make you feel socially isolated. Next. Driving, that's hard. Okay, there's no way, hard subject, just got to be honest. Every state's really different. Wyoming, you have to be 3 months seizure free, and a clinician has to, you have to get signed off. It's very strict on one end and very loose on the other end. We are, in Colorado, in general, we recommend 6 to 12 months seizure free before driving. And depending on the seizure type, sometimes we recommend an overnight EEG before driving as well. If someone does have a seizure, we generally recommend stopping driving, readjust your medications, stop driving for 6 months, and then consider driving again. In Colorado, when it comes to driving, so clinicians are different from person to person. So that 6 to 12 months guideline is a little different from person to person. I have never seen anyone recommend less than 6 months. I don't report to the DMV unless I have a big safety concern, but it is up to the person driving to fill out on the bottom of the form. There'll be a question that says, have you ever had a loss of consciousness or seizures? And then if you hit yes, it will require that you have the signature with a brief explanation from your provider. Next. Pregnancy. So usually not my jam, right, in pediatrics, but pregnancy is totally normal and okay to become pregnant if you have epilepsy. It is considered a high-risk pregnancy if someone should get diagnosed is diagnosed with epilepsy that does get pregnant. And the reasons are many, and I'll just go into a couple. One, I think being pregnant changes your estrogen, which can affect your drug levels. Pregnancy can increase seizure risk. We also don't want the mom to have a seizure. We don't want the baby to have a seizure. So it would be important to, if anyone's on anti-seizure medications and sexually active, that they use 2 forms of birth control in general is extra safe. If they do plan to become pregnant, that they should talk to their neurologist and let them know that that's what they're planning. There are medications that are higher risk and lower risk for the fetus and baby. So those are things to take into consideration when family planning, but we do have people with epilepsy who do get pregnant. Next. First aid, what to do? Easier said than done, stay calm. I see seizures daily, and I still sometimes have an initial and then I'm like, okay, do the things, right? Chelsea, you know how to do this. So one, time the seizure. So the first thing to do would be to make sure you keep track of the time. Stay calm the best that you can. Clear the area. Now you don't have to go crazy, but you don't want them, anything that they could kind of hit, you want to move. Loosen tight clothing. In general for kids, that's like mainly hoodie strings, but do you have to go like scissoring off their t-shirts? No, it's just anything like around the neck, specifically like a tie. Turn them on their side and put something flat and soft under their head. I had come into a conundrum when I was at camp of I didn't have anything soft near me. We were on like the basketball court. Where does this kid's head go? Your hands have tiny little bones. And I didn't know what to do with this kiddo's head. So I put it on my lap, on my legs. Which I felt like was a reasonable solution because that's softer than the ground. But his skull was much bigger than my finger bones. So I also didn't want injury, right? So I put his head on my lap because I didn't have a soft, firm blanket near me, and that seemed to work great. So I recommend that if you're really in a pinch. Don't panic. Don't put anything in their mouth. They cannot swallow their tongue. I know the first time for a lot of people, the first time they see a loved one seizing, they often do like a finger sweep to make sure they're not choking. That's really common, but from now on, once you have the diagnosis of epilepsy, don't put anything in their mouth for multiple reasons. One, you can't swallow your tongue. I recommend everyone try swallowing your tongue. It's really quite difficult. Two, putting anything in your mouth, if you put like a spoon in their mouth, that was like the old thing, put a spoon in their mouth. If you put a spoon in their mouth and they clamp down, they will chip their teeth. If you put your finger in there, they could break your finger. And hurt their teeth. But don't put anything in their mouth. Allow them they will have foam. They may even vomit when the seizure is over. Just tip them on their side so that all can come out naturally. And don't attempt artificial respiration during the seizure. Next. So rescue therapies. Most people with epilepsy take seizure medications on a regular basis to prevent seizures, but sometimes additional medicines are needed. Rescue treatments are taken as needed to try to prevent a seizure emergency from occurring. They're not used instead of daily medications. If someone has regular seizures, we do recommend that they're on anti-seizure drugs. If seizures do not stop after using a rescue therapy, we do recommend that people call 911. Next. There are lots of types. So the original one was rectal diastat. That has been around for some time. Those are syringes that go in the rectum. They are usually pre-dialed by the pharmacist. So you would see like a little green window that says the exact medication and the dose. And it would be 2.5, 5, 7.5, or 10. And it goes in the bottom. You take off that big plastic cap on the top, and then you place the child on their side, and usually bending the top knee up a little bit is helpful. Once you have the plunger in the rectum, you kind of have to take a mental break and go, okay, and say, okay, 1, 2, 3. So you push the medication actually in slowly, 1, 2, 3. Hold it there at the buttocks, 1, 2, 3. Take it out quickly, squeeze their little butt cheeks together, 1, 2, 3. And that allows to kind of increase maximum absorption to make sure that it doesn't come flying back out. If you try to inject it too fast, it could, if there's any resistance, it'll just come back out. So you do kind of want to do 1, 2, 3, hold it there, 1, 2, 3, butt cheek sandwich, 1, 2, 3. So that is rectal diastat. It's used usually in younger kids or adults with developmental differences. So next, please. There's a demonstration. I just explained that all. I forgot that was there. Next. Nasal Midazolam. So this is, we have been using this a little bit more. It's not FDA indicated at this junction. Really only Diastat and then Nasolam, which I'll talk about later, for over the age of 12 are approved. We've been using nasal midazolam off-label Lots of institutions are doing it. It's inexpensive, and it is a nasal spray that goes obviously in the nose instead of the bottom, so that's helpful. The hard part is there are a few steps to this that can, in an emergency, sometimes parents can get a little flustered. So when we prescribe it, we recommend that parents watch a video and do a teaching with a nurse. But you basically have that syringe right there, the needle, which is obviously the pointy thing, the little green vial of medication, and then that cone-shaped thing is the atomizer. And the first thing you do is put the needle onto the syringe, draw up the medication that is dosed on the vial. If it says 2 mLs, 1.6 mLs, however much, then you twist that needle off. That, if you can tell on the picture, that needle has like a little pink hub. That pink thing screws onto the top and screws off. And so you screw off the needle, put on the atomizer, and you put it in their nose, and you spray kind of out towards the ear a little bit. In general, so in doing this, I often will have I done this, I put them on their side during their seizure, and then I will actually realign their head to look at me to spray it in, and then I put them back on their side. So you give half the dose in each nostril. Doesn't have to be exactly 50-50. No, it can be 60-40. The thing that we can come across is that parents get so nervous about using this medication, they'll push the syringe really, really slowly, which is what you want to do with Diastat. But in this one, you actually do want to create a mist with that atomizer. So you do have to give it a little bit of a push. So that's why I kind of say of about 50%, because you do want you to push it enough so that it actually has enough to make a mist. If you just barely push it, it'll kind of dribble out, and then that's not very effective at getting absorbed in the mucous membranes of the nose. So you do want to give it a good push on one side and a good push on the other, and then I would put them back on their side. So next. So Nasolam. So this is the only nasal midazolam that has been approved for treatment of seizure clusters. It can be given by anyone. You don't necessarily need to be taught for this. It's a prescription medication approved for short-term treatment of seizure clusters in patients 12 years and older. We use the other nasal Versed for kiddos under 12 and for single convulsive seizures, and Nasolam for kiddos over 12 who are having acute repetitive clusters, acute repetitive seizures, which we call clusters. Next. The first dose, so Nasolam, the first dose, use 1 5 milligrams. So each spray is 5 milligrams in one nostril. If the cluster lasts longer than 10 minutes after the first dose, a second dose can be used. Don't give more than 2 doses to treat it. Don't try to prime the nasal spray before you use, because then you'll actually like lose a little bit. So don't do like what you see in like Grey's Anatomy where they like squirt it a little bit. That's with IVs and stuff that get the air out. That's the other thing about the nasal Versed. You don't want to do that either. Lots of people will try to do the thing that they see in like medical shows where they try to get all the air out. It does not matter if you give air into the nostril, right? It is not good for you to give air in a vein, but don't try to get all the air out of the nasal Versed, because it is perfectly fine. You don't want to lose medication, and it's perfectly fine and safe to put air in the nose. I can't think of a better place for air to go. And there obviously is more information about Nasolam online. So next, please. What to do during non-convulsive seizures? Keep calm. It's pretty similar. Keep calm, time the seizure, watch the person, try to gently direct them, guide them away from things that are dangerous. Those are all pretty common. Time the seizure as well. You may need to use a rescue medication. In general, for a seizure where they are only somewhat impaired, where they're not on the floor shaking, but they're what we call dyscognitive, which is where you're altered, we usually rescue around 10 minutes or so. So, I mean, if you rescued them at 9 minutes, no one would fault you, right? But yeah, you tend to just kind of want to not overreact, maybe tell a couple people what's happening and allow the seizure to just end naturally unless you need to administer a rescue medication. Next. So this is my slide for Help Me Help You. If I can ask one thing of families, in my, experiences with them, how, I work Monday through Friday, actually Tuesday through Saturday. So I work 5 days a week, but I'm gone some, and I often sometimes go on vacation, or you need to call after 5 p.m. and you may be talking to someone that's not me, who doesn't know your patient or you off the top of your head. So these are things that will help you communicate effectively with people after hours who are not your primary clinician. Knowing your seizure types. So I have convulsions, I have focal unaware seizures, I have absence seizures only. What is the name of the seizure? What is the official name? How often do you have seizures? For some people, having multiple seizures per day is very normal. For some people, having 1 to 2 seizures per year is very abnormal, and that's way too much. So it really depends. So you kind of have to say, like, a normal frequency is this, or it's none, and this is a huge increase from where I was at. Medication changes in current doses. So what is, little white pill is not helpful. Little red pill is not all that helpful. Saying I am taking Lamictal 100 milligrams twice a day, that is helpful. I am taking, clobazam 10 mLs twice a day, that's helpful. Side effects to your medication, so that you can communicate, the reason why I'm only at this much of Depakote is because I got tired at the higher dose. Oh, okay, so I won't make that change, So knowing why, if you've had side effects to certain medications when you go up. Safety plan, so what is your rescue plan talked about with your provider? In general, it tends to be seizures at 5 minutes or focal unaware seizures at 10 minutes, but some people have multi-steps. Some people rescue after the first minute or two because their seizures are classically known to be very long. So it really is pretty different from kiddo to person to person. So I would talk with your clinician about when you would give those rescue medications. Next. Seizure alert dogs. This is hard. This was hard. So I gave this lecture earlier this year, and I quickly became a non-expert in seizure alert dogs because apparently there is no such thing as an expert in seizure alert dogs. The top 2 lines are my favorite thing about why this is a difficult subject. When I did a search, a PubMed search, which is just where we look for articles, and I looked up lamotrigine, which is a very common anti-seizure drug, and seizures, I got 1,391 results. When I looked up seizure alert dogs, I got 12. So there's just not a lot of data. So I will say that it's very hard to study. So in like the late 90s and early 2000s, there was some data that came out. It was from a company that did like seizure alert dog training. Then I think in like 2006 or 7, there was an article that came out. And then after that, articles about seizure alert dogs were pretty infrequent. That kind of, it was like skepticism. It was called Wag the Dog, and it was skepticism on seizure alert dogs and family and seizures. Noting that seizure alert dogs kind of increase the frequency of which families might, when a seizure alert dog reacts to a child having a panic attack, it kind of often sometimes looks to someone having a real seizure. That's a thing. Or some seizure alert dogs never actually, start to alert for that kiddo. Let's see, so the main thing that they quoted in that Wag the Dog is my kind of middle paragraph there, that they had a person who was admitted, and the seizure alert dog alerted for a seizure, but also alerted for something that was not a seizure, and therefore the person had interpreted other things as being seizures that actually weren't. So that was a little bit hard. In general, I recommend people to always be mindful of the sick role that a service dog can enforce. So when you have a dog with you, people may think that you are therefore different. That being said, people who have seizure alert dogs say that their seizures are less, they're happier. Sometimes a seizure alert dog is a point of conversation. So really, it's a decision I can't ever make for people. And if you're there, then you do it. But I think those are things that you have to think about before you go down this venture. Next slide. So Wag the Dog, that was the thing. The interesting thing in here is that it's in there somewhere. So 20%, so like 36% of trained dogs, no. According to their owners, 36% of the untrained dogs started spontaneously anticipating seizures. So your average family dog has relatively similar alerting frequencies as the trained dogs. They're pretty similar. What trained dogs have that the family dog, my family dog, would not be very helpful from day to day. So he'd be useless actually. But I mean, if I were having a seizure and I was alone in my room, I do think he would act differently. So the issue would be if I had other needs like physical needs, if I needed help opening door, doing things like that, my dog would be entirely useless. But some people, lots of people have noted that the average family puppy will actually start to alert for their families. So in general, when parents are thinking, do I bite off this very expensive investment? I've seen a fair number of seizure dogs not also alert either, even if trained very well. So I say, maybe consider getting a puppy and making that because there's just not a lot of research, right? So that's the hard thing, is not after like 2006 or 7, after this came out, there just has not been a robust amount of research. I usually tell them have a dog that is that person's dog, sleep with them, be their dog. If that, then maybe talk about the seizure alerting dog. It can be pretty expensive. Can be a process to get it. Some people do like crowdfunding and things like that for that. So it isn't a decision that anyone can really make with a lot of sound medical advice. So I wish I had more information on that, but really, like I said, there's 12 articles that exist. So next, please. Devices. So devices. There are several. I'm going to go over 3 main different ones. The MFit is a mattress pad that goes under. It has high frequency alert if the movements they feel meet a certain like computer program for frequency and strength. There was a prospective study out of Tennessee. In 45 patients, 78 seizures were recorded, 15 of the 28 that occurred during sleep. Most importantly, the alarm was activated with 83% of generalized tonic-clonic seizures. So it does miss things like focal seizures, partial seizures. It's very good at getting tonic-clonic seizures at night when the person's sleeping, but other types of seizures are not captured. The other thing I've heard is it's not good for, it doesn't do well with incontinence. So when people lose their bladder when they seize, that can damage the device, and it's around $249. Next, please. The Embrace watch. So I believe, yes, so this is a watch that you wear. It collects physiological data, kind of similar to the MFit in that it has an algorithm to detect a certain type of movement frequency. You use the internet and it sends a text to the activated caregivers. And multiple people had a rate of false alarms that were lower than their seizure rate. No false alarms occurred during resting periods. So the issue would be, would it wake you up for things that aren't seizures? It rarely misses actual seizures, which is good, but then, that's kind of hard too. So there's not a ton of data on that, to be honest. It also does come with an app. And if you're not connected to that, or if you're not within 30 feet of the kiddo so you can't like have this, you can't have 2 separate houses with this, really. You have to be within 30 feet to have, that phone has to be 30 feet within that device. Now that phone can send a text to another phone, but so I guess you could have it to your own phone and then have your phone at a different house. But that can be a limiting factor, that the phone, because lots of people like to get this for like college students, but it doesn't really work because the phone has to be within 30 feet. Next, please.
Sure, and Chelsea, I'm just going to give you like a 5-minute warning so we have enough time for Q&A at the end.
Okay, cool. Yeah. Next. I think I'm actually getting towards the end-ish. The SAMI that was made here in Colorado, I know who made it. It is actually a patient favorite of ours, though it doesn't have an FDA, sorry, the watch has an FDA indication. This does not, but it's a lot of parents really like it. It's a video monitor that can actually has the algorithm to monitor the way that people sleep and their movements to detect convulsions. The nice thing about it that parents really like is being able to look back at the night and see if they had any seizures that they missed. So it can have some false alarms with restless sleepers. Next, I'll keep cruising. My last subject, the one to end on, is SUDEP, sudden unexpected death in epilepsy, and it is hard. Next. SUDEP is a sudden unexpected death in someone with epilepsy who is otherwise healthy. In SUDEP cases, no other cases of death is found when an autopsy is done. Sudden unexpected death in epilepsy causes between 2 and 18% of all deaths in epilepsy. The lifetime risk by 40 is about 7%, with the total lifetime risk of SUDEP when epilepsy being 35%. SUDEP is rarely witnessed. Usually most events of SUDEP usually occur in the context of a seizure in sleep. So most people walk in to find a loved one down. Next. What causes SUDEP? And we don't have one exact answer, but we do have a lot of data that says that people get bradycardia, or a low heart rate that occurs in 3.7% of people with seizures, like a very almost asystole, which like your heart rate almost stops, heart rate problems. So we've seen that kiddos' the way that their heartbeat is very different during seizures. Is a respiratory, ictal apnea occurs in 47%. Most are central in origin, meaning that it's not from here that's blocking it. It's because your brain's not functioning well enough to breathe. So there have been, next please. There are lots of things. We're not 100% sure exactly the pathophysiology. We do think it's some sort of heart-lung connection. Risk factors, the most important risk factor is the presence of tonic-clonic seizures. Tonic-clonic seizures increase your risk of SUDEP tenfold. Having tonic-clonic seizures, your risk of having GTCs increase your risk of SUDEP 10 times, and having more than 15 GTCs per year increase your risk of SUDEP 15 times. Most SUDEP cases occur in ages 18 to 40. Other things that can be related but don't have great data is lack of seizure freedom, nocturnal seizures more than daytime seizures, high number of anti-seizure drugs, intellectual disability, male, prone position, but that's not got good data either. Next, please. In a meta-analysis, basically that first line means that people taking their anti-seizure drugs were seen to have seizures less. Supervision at night can be helpful to prevent SUDEP. The issue is, though, that the American Epilepsy Society, because there's not robust head-to-head data, SUDEP is still infrequent. It's hard to study, so there's not really robust data on saying which device reduces SUDEP. There's not great data behind each device, one of those monitoring devices, but we do know that monitoring can decrease the risk of SUDEP from that study there. In the third line down, but the value of the devices kind of remains to be unproven. So we don't really have an official device or stance that can really guide families in this matter. I know that I would probably want a device, but I don't know which one I would pick. I know that it's the best way to reduce the risk of SUDEP is to control seizures.